Morning, everyone. Before we started the class, I have a question. Do you know one kind of disease? The patients, for some reasons, suddenly serious pain, and this pain, very serious pain, can reflect to left shoulder. Do you know the disease? Angina, yes, angina pectoris. So today we will study the drugs used to treat angina pectoris. At first, we should know something about angina pectoris. The definition of angina, that means decreased coronary blood flow cannot meet the myocardial demand for oxygen. Angina attack is characterized by sudden, severe, present substantial chest pain, and this chest pain, this ischemic reperfusion, clinically may develop arrhythmias, myocardial infarction, heart failure, or sudden death. And we divide angina into three subtypes. The first case, most patients, they are stable angina. And what's the meaning stable angina? The patients know the reason why they suddenly serious pain, because their oxygen consumption suddenly increase. And this stable form will give nitroglycerin, very useful. The first case. And the second subtype of angina, we call this variant angina. The patients, they don't know the reason. And maybe they tell you, doctors, oh, I fall asleep, suddenly pain. And as a doctor, you should know the reason, because their coronary vessel suddenly spasm. So we call these patients, they are variant angina. And in fact, your first choice agent isn't nitroglycerin, should be CCB, calcium channel blockers. And angina stable variant angina later frequently occurs, and serious, we call them unstable angina. We know the heart oxygen supply comes from coronary vessel, and this oxygen supply used to increase myocardial contractility and increase heart rate or increase ventricular wall tension. In this, ventricular wall tension also determined by vascular pressure, ventricular volume. So in our angina pectoris patients, their oxygen supply and oxygen demand imbalance. Demand exceeds supply. For example, maybe the patient's atherosclerosis disease, maybe the patient's the heart blockade, vessel blockade. So blood supply reduced and couldn't meet oxygen demand. Or on the other hand, heart rate increase, or myocardial contractility increase, or ventricular wall tension increase. That means oxygen consumption increase. So this imbalance induces myocardial ischemia and induce the patients with angina pectoris, and also induce left ventricular dysfunction and ST view reduced. We call arrhythmias. So now we know the reason why the patient's angina pectoris, because demand exceeds supply. Okay, so the imbalance. So that means later we want to treat angina pectoris. The drugs should meet three demands. The first one, the drugs used to treatment of angina should have vasodilation effects, or reduce heart rate, or reduce left ventricular and diastolic pressure. That means these drugs should reduce oxygen consumption. On the other hand, the second pathway, the drugs used to treat angina pectoris also should relax coronary vessel, increase blood supply, and increase oxygen supply, can use to treat angina pectoris. At the same time, if the drug can improve myocardial metabolism, improve cardiac function, it's very useful for angina pectoris patients. So in clinic, we have three kinds of drugs used to treatment of angina pectoris. The first kind, we call this nitrate esterase, and the prototypical agent is nitroglycerin. So later, we will study nitroglycerin's pharmacological effects, clinical using, and at the same time, have which kind of adverse reactions. Second case, the drug beta receptor blockers. Do you remember you have studied a beta receptor blocker? In clinic, the most widely used beta receptor blocker is propranolol, metoprolol. And the third case, we also studied CCB, calcium channel blockers. Calcium channel blockers mainly used to treat heart and vessel disease. So today, we also use calcium channel blockers to treat angina pectoris. So now I have a question. In your mind, if you treat angina, heart disease, in CCB, verapamil and nifedipine, you will use which drug to treat angina pectoris? Verapamil? Yeah, maybe, but later we also use nifedipine. Okay. So the first drug, nitroglycerin. Nitroglycerin, because can be destroyed by gastric acid, because you studied one definition, we call this first pass elimination. So we couldn't oral administration. So in clinic, the most commonly we use nitroglycerin. The method is? Yes, very good. Sublingual administration. And if we sublingual administration, nitroglycerin and can be absorbed easily, quickly, in 30 seconds to 1 minute, and 1 to 3 minutes, high concentration will have the best therapeutic effects. The effects can prolong 15 to 30 minutes. So the drugs are very useful and can save the life. If the myocardial infarction patients, if they can nitroglycerin the drugs and successful, that means can save their life, can hugely reduce the infarction size, and can save 50% lives. So nitroglycerin, very old drugs. The drugs used in clinic more than 160 years. But we still use nitroglycerin to treat angina pectoris as the first choice. So very useful, very useful. And just now we mentioned, we want to treat angina, we need drugs meet 3 requirements. Do you remember the first one? The drugs should reduce oxygen consumption. Yes, excellent. Nitroglycerin can reduce oxygen consumption. In normal or lower doses, can relax venous. Relax venous means retain the blood volume and reduce preload. So oxygen consumption reduced. It's very useful for angina pectoris. If we use high doses, nitroglycerin not only relax venous, but also at the same time can relax atrial. So by atrial dilation and intraventricular pressure and tension reduced hugely. So oxygen consumption reduced hugely. So for this reason, nitroglycerin can relax venous and atrial, so meet the first requirement, reduce oxygen consumption. Oh, we can use to treatment of angina. Second, pharmacological effects. Just now we mentioned. Oh, we also need a drug increase oxygen supply. Yes. Nitroglycerin can relax coronary artery, so increase blood supply, increase oxygen supply. In angina pectoris patients, and in infarction sites or ischemic region relax because a lot of substances accumulation, such as hydrobradykinin, so lower prior. That means ischemic region, the prior less than unischemic region. Once we give nitroglycerin and the drugs follow different prior push the drug from unischemic region to ischemic region and increase ischemic region blood supply. So we use this picture, explain this again. For some reason, the patients maybe for sclerosis or spiral, and here is the ischemic region. In ischemic region, bradykinin, hydrogen, and accumulation in here. So lower prior. After we give the drugs, we give nitroglycerin because here is the low prior and here is the higher than ischemic region. So after we give nitroglycerin, that means the drugs from here push to ischemic region, increase ischemic region blood supply. Nitroglycerin also can reduce left ventricular fusion prior and increase ischemic region, especially here increase endocardium blood supply. So we know, for example, our heart and the outer layer, inner layer. Outer layer, the vessel, this level, but inner layer, the venous streets, okay? This blood supply determined by intraventricular pressure and ventricular wall tension. After we use nitroglycerin and nitroglycerin vasodilation, so hugely reduce intraventricular pressure and also induce ventricular wall tension. So here, this straight vessel and be relaxed hugely. That means mainly increase, especially increase endocardium blood supply. And for angina pectoris patients, very useful. So just now we mentioned two requirements. Reduce oxygen consumption, at the same time increase oxygen supply. And we also need the drugs can improve cardiac function. So nitroglycerin, yes, can protect myocardium. Because nitroglycerin can release nitric oxide, prostaglandin I2, and these factors can protect myocardium. If the patients, if they can as early as possible use nitroglycerin, can hugely reduce infarction size and can improve remodeling and hypertrophy. For angina pectoris patients, even for acute myocardial infarction patients, very useful. So for these three reasons, the first one, increase oxygen supply. Second one, decrease oxygen demand. And the third one, yes, protect, yes. So we can use to treat anemia. So let's study nitroglycerin's clinical using. Nitroglycerin today we use to treatment of anemia. And just now we also divide anemia into how many subtypes? Three, yes. Three subtypes. All subtypes anemia, we can use nitroglycerin. Especially most patients, they are stable anemia. We know the reason why they suddenly serious pain, because their oxygen consumption usually increase. So for these patients, most patients, they are stable anemia. Nitroglycerin is the first choice agent. And sublingual administration for frequently occurs for unstable patients. We can intravenous drop nitroglycerin. And except angina pectoris, also can use for treatment of acute myocardial infection, especially in the early period. If the patients can use the drugs as early as possible, that's a no method, can save their life. So 60% of patients, if they can sublingual administration nitroglycerin, can save their life, acute myocardial infection patients. And also used to treat chronic heart failure, congestive heart failure. So now I have a question. Which kind of congestive heart failure patients? First, second, and third or fourth states? Which kind of states? Mild, moderate, or serious patients? Serious, yes. The fourth states heart failure patients will use vasodilators, such as nitroglycerin. And other patients, for example, respiratory failure and pulmonary hypertension. At first, we know used to treat stable anemia as the first choice. So now we should know the adverse reaction. The adverse reaction of nitroglycerin are the consequence of vasodilation. So for example, vasodilation, blood pressure decrease, so maybe induce positive hypotension. And cerebral vasodilation and blood supply increase. And the patient's intracranial pressure increase. And the patients, yes, they will tell you, doctor, I use the drugs and a very serious pain, headache, and we call this pastel headache, tung. Why? Because vasodilation, because blood supply increase. So you should tell them, don't worry about it, never mind. Why? Because after the effects and the headache disappear, okay? But you should know here, blood pressure reduced, and then reflectivity in your physiological class we have known. Yes, heart rate will increase. So now I have a question. For this reason, we use nitroglycerin. Also increase heart rate. That means also increase oxygen consumption. Maybe also induce anemia. So how to treat this? Can we co-administrate with kind of drugs? Excellent, yes. We can co-administrate with beta receptor blockers, such as metololo. Excellent, yes. We use in clinic, we use nitroglycerin to treat stable, unstable anemia as the first choice, but should co-administrate with beta receptor blocker to reduce heart rate. And patients long-term use nitroglycerin, yes, will have tolerance, dependence. And you should tell the patients they should discontinue the drugs 1 to 2 months, and then, yes, still have the good therapeutic effects. The first catch, nitroglycerin. In clinic, the second kind of drugs used to treatment of anemia are beta receptor blockers. So we studied beta receptor blockers, and today we need beta receptor blocker meet 3 requirements. The first one, yes, should reduce oxygen consumption. Beta receptor blocker have negative inotropic action, means that reduce contractility. Have negative chronotropic action, means reduce heart rate, inhibit conduction. So that means reduce oxygen consumption. And second requirements, increase blood supply. Beta receptor blocker same with nitroglycerin. So follow with different spiral. push the drug from an ischemic region to ischemic region, increase blood supply. And the third one, beta receptor blocker, can block beta-3 these subtypes and can improve myocardial metabolism, reduce free fatty acid, and increase glycol metabolism, reduce oxygen consumption at the same time, improve cardiac function. Very useful for angina pectoris. We use beta receptor blocker to treat angina. 3 kinds. The first one, stable angina. Stable form, yes, we should use beta receptor blocker, but we still remember the first choice agent is nitroglycerin and co-administered with beta receptor blocker, the best method to treat angina. And the second one frequently occurs, serious patients. We call them unstable angina. Unstable angina causes. Why? Maybe the patient's myocardial infarction, heart failure. So beta receptor blocker, use or don't use, it's up to you, to patient's conditions, okay? And few patients, you know the reason why they suddenly serious pain. We call them variant angina. Variant angina, we know the reason. Their coronary vessel suddenly spiral, yeah. So these patients, beta receptor blocker should as the contraindications. Do you remember which kind of drugs used to treat variant angina as the first choice? CCB, yes. So the third kind of drugs, later we will mention CCB. Beta receptor blocker used to treat angina. You should pay attention to this idle section. For example, dose. And the patients should gradually increase the doses. If once they want to discontinue the drug, they should know gradually decrease the doses. And the second one, the patients, you should know heart failure patients, bradycardia patients, maybe aggravate cardiac function as the contraindications. And unselectivity beta receptor blocker, such as propranolol, yes, also block beta-2 receptor, so maybe induce asthma. Asthma patients should as the contraindications. The third kind of drugs we use to treat angina are CCB, calcium channel blockers. Before we study calcium channel blocker, we have how many drugs, prototypical agents in clinic in CCB. One is verapamil, the other one is nifedipine, yes. So which drug we should use to treat angina pectoris? Okay, so the first one, we also need calcium channel blocker, meet 3 requirements. The first one, calcium channel blocker should reduce oxygen consumption. Why? Because we know calcium channel blocker block calcium channel. Calcium reduce. We know calcium excitation, relaxation, coupling. So inhibit and vasodilation. Hugely reduce afterload, reduce oxygen consumption. And calcium reduced also on heart negative inotropic action. So contractility reduced, negative chronotropic action, heart rate conduction inhibited. So oxygen consumption reduced. The second requirement, CCB should increase blood supply. CCB can relax coronary artery and increase blood supply. But just now we mentioned 2 kinds of agents, nitroglycerin and beta receptor blocker. The drugs, these 2 kinds of drugs, follow different spiral and push the drug from ischemic region to ischemic region, but CCB different. Calcium channel blocker increase collateral circulation. So what's the meaning? Oh, this vessel blockade from other pathways and increase ischemic region blood supply. The third one, calcium channel blocker also can protect ischemic myocardium. Why? Because they are calcium channel blockers. We know calcium overactivity will increase free radical. Oh, that means reduce calcium overdose, reduce free radical can protect ischemic myocardium. So today, we studied the third kind of drugs, CCB, calcium channel blocker to treat anemia. And the first one, you should know variant anemia. Variant anemia, the patients suddenly serious pain, maybe fall asleep, suddenly serious pain. And you should know the reason. Why? Because their coronary vessel spasm. So for these patients, CCB is the first choice agent. You can co-administer it with nitroglycerin, but nitroglycerin, the therapeutic effects not very good. The first choice should be CCB, calcium channel blockers. In calcium channel blocker, verapamil or nifedipine, you use which drugs? Nifedipine, yes, because nifedipine higher sensitivity on vessel, higher sensitivity on spasmodic vessel. So for variant anemia, the first choice agent should be nifedipine and then co-administered with nitroglycerin. The second one, stable anemia. Stable anemia and unstable anemia. Your first choice agent should be which agent? Nitroglycerin, beta receptor blocker, CCB. Nitroglycerin. And you can co-administer it with beta receptor blocker. Or you also can co-administer it with CCB. But now I have a question. If you co-administer it with CCB to treat a stable, unstable anemia, in calcium channel blocker, verapamil and nifedipine, which drug you should use? Verapamil. Why? Because nifedipine, vasodilation, blood pressure reduced, reflectivity, heart rate increase. Same adverse action with nitroglycerin. So we use verapamil because verapamil negative chronotropic action on heart. Let's summarize. Today, we studied the drugs used to treatment of anemia pectoris. Three kinds of agents. The first case, nitroglycerin, still used to treat stable, unstable as the first choice. And the second one, beta receptor blocker, can co-administer with CCB or nitroglycerin to treat stable, unstable anemia. And the third case, calcium channel blockers, mainly used to treat variant anemia, all stable, unstable. Okay? So, thank you for your attention.